Good afternoon, everyone. Thank you so much for joining us for our Parenting at Mealtime and Playtime program session on obesity management prevention. This training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program. In its 20th year of funding, Parenting at Mealtime and Playtime has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. This year, PMP will focus on adolescent health and supporting the providers that care for them. This year, Ohio AAP is excited to continue the work of PMP and looks forward to diversifying its topics. If you have any ideas for the toolkit, mobile app, or any of our other resources throughout today's session, please share your ideas in the chat or reach out to me, the PMP Program Manager. We always appreciate feedback from our learners. Slides from today's session will be shared in a follow-up email. Thank you to our funder, the Ohio Department of Health, for funding this education session and for supporting the health and wellness of children in Ohio. The planners, faculty, and others in control of the content have no relevant financial relationships with ineligible companies. And we have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any concerns or comments, please contact Dr. Kelsey Logan at kelsey.logan@cchmc.org. A couple of housekeeping items. Again, the slides will be shared after the session today. Please keep your audio and your video off. With that, today's training is hosted by Dr. Chris Bowling and Dr. Eileen Chavez. Dr. Christopher Bowling is a volunteer professor of pediatrics at the University of Cincinnati College of Medicine. A graduate of the University of Cincinnati College of Medicine and the Pediatric Training Program at the Cincinnati Children's Hospital Medical Center, he co-founded Pediatric Associates in the Northern Kentucky suburbs of Cincinnati in 1992. Over the ensuing 30 years, Pediatric Associates became one of the largest single-specialty pediatric practices in the country. Dr. Bowling retired from Pediatric Associates in December 2022. After residency and during a 3-year appointment mid-career at Cincinnati Children's, he pursued research, advocacy, and clinical skills related to the prevention and management of pediatric obesity. He helped found the American Academy of Pediatrics section on obesity in 2009 and served on the section executive committee and as chair through 2019. He's published in the area of behavior change, obesity treatment, and community research. Most recently, he's been a co-author of the AAP Policy Statements on Bariatric Surgery and of the AAP Clinical Practice Guideline on the Evaluation and Treatment of Overweight and Obesity in Children and Adolescents, and the AAP Policy Statement, The Role of the Pediatrician in Healthy Active Living. He remains engaged in quality improvement, education, advocacy, and research activities. Eileen Chavez is a pediatric psychologist at Nationwide Children's Hospital in the Center for Healthy Weight and Nutrition, and an assistant professor at the Ohio State University College of Medicine. Dr. Chavez obtained a PhD in counseling psychology from the University of Denver. Dr. Chavez's clinical work and research focuses on better understanding how mental health and family dynamics affect the treatment of child and adolescent obesity. She has lectured nationally on the topics of weight bias and stigma and eating disorders and disordered eating in pediatric obesity. She currently serves on multiple national work groups and committees within the American Psychological Association and Division 54 Society of Pediatric Psychology and serves on the APA's Committee on Children, Youth, and Families. Dr. Chavez also serves as the chair of Division 54's Obesity SIG, as well as the Promoting Equity in Pediatric Psychology PEP Undergraduate Psychology Mentorship Program. Thank you, Dr. Bowling and Chavez, for being here today.
Thank you so much for that really kind introduction, Suhavi. And thank you for just being here and hearing our talk. Any talk that I give, excuse me, I really like to start with just acknowledging all of the wonderful kids and families that I've worked with. I have been amazingly honored to be able to work and learn from all of the families and all of the patients that I have seen. And so I just like to spend a second to recognize that what we're about to say really truly is for the kids and the families that we see every single day. And without them having helped me understand their experiences and taught me different things that they know about their own bodies and about their own lives, I don't think I would be able to share with you what we're about to share today. So I like to thank them at the beginning of all of this. Next slide, please. So we're going to try to talk about a number of things today. We are first going to discuss what healthy, active living looks like for families and how we can kind of help families engage in those behaviors. We're going to talk a little bit about weight bias and stigma and how we can begin to start to integrate compassionate care into the work that we do with kids and families. We're going to talk a little bit about motivational interviewing and how we kind of can begin to implement some of those skills into the work that we do. And last but not least, we're going to talk a little bit about how we can help promote healthy feeding habits for families and kids. Next slide, please. So I want to pause real quick on this slide and just have everyone kind of look at this word cloud. And if you were to kind of guess, like if we were to give this word cloud a title, what would you guess the title of this would be? We might take like 5 seconds here, and if you just want to put your answers in the chat, that would be lovely. Sorry, I'm going to see if I can see the chat. Does anyone have any guesses? Social media, yep. What else? Weight stigma. Body image, yep. Oh, I love that one. How patients feel sometimes. Yep. Yep. How body size is viewed different or described. hmm Internal noise. All of those are great responses. Wonderful. Thank you, everybody. Yep. Um, I agree with all of them, right? Like there is no one right answer. When I was making this slide, I was really thinking about weight bias and stigma and all the experiences kids and families come and tell us about. So I think all of those are right on. Next slide, please. Which leads us to let's talk about what weight bias is. Next slide. So real quick before, oh, can you go back 1 second, Chris? Okay. Nope. One more. One more. Yep. Before the picture. That's okay. Never mind. Um, so what I want everyone to kind of do is I am going to read out all of the different words on the side and just sort of I think about it like, when we were kids and we would see those workbook pages where you would like draw lines and connect like pictures on one side with like maybe words on the other side to see kind of what goes together. I like to think about it like this, right? So I'm going to say a bunch of different sort of words, and just in your mind, really quickly, think about which word kind of goes to which family for you. You want to do one more click? Perfect. Okay. So, of these two families, which family do you think runs 5Ks together? Which family would you think of as being organized? Which of these families really enjoys going out to eat fast food together? If we were to focus just on the kids, which set of kids would you think of as leaders? And which set of kids would you think of as being more likely to be bullied? Which family likes to be outside and outdoors together? Which kids would you say they're a little weird, they're a little awkward? And last one, which family would you sort of automatically think that that family must hate exercise? Okay, next slide, please. So we do that really to just kind of help our minds connect and recognize that everybody has weight bias and stigma. Please know that is very normal. And we just want to make sure that when we notice bias thoughts, we can kind of catch them. So, the definition of weight bias are really attitudes or beliefs that we have about other people because of their weight, their body size, or their body shape. Like I said, everybody has bias. There are lots of different types of bias. We're speaking specifically about weight bias. Um, But we have bias because we have grown up in our society. We've been exposed to different family members or friends' beliefs about body size and shape. Um, we've been exposed to social media that talks about body size and shape a certain way, just traditional print media as well. We might have had our own experiences. Everybody has a body image, right? So we might have had our own experiences because of our body size or shape, or the body size and shape of our family members. So weight bias or bias can be either implicit or explicit. Implicit bias are really those automatic unconscious thoughts that kind of just pop into our head when we see something specific or experience something specific. Um, and we don't really notice them. Explicit bias is where that thought about somebody based on their weight, size, or body shape pops into our head and we kind of catch it. I like to think about like catching it in a trap, and making that thought sort of conscious so we can kind of say, okay, I recognize I'm having that thought. Where's that coming from? Do I want to choose to act on it or not? Next slide, please. Unfortunately, sometimes what can happen is if we don't make those bias thoughts explicit and they continue to be implicit, they may turn into weight stigma. And weight stigma are really just actions that are taken against people due to them having obesity or due to their body size or shape. Um, which can definitely lead to negative effects. So we see a lot of kids who talk to us about having experienced weight-based teasing and bullying by peers or even by like coaches or other family members or teachers. Um, Kids might talk about feeling excluded or marginalized, like they're just not picked to be played with on the playground. And we know in the healthcare setting, it can lead to lots of different disparities in care and treatment. Research has definitely shown that for people in larger body sizes, medical providers often tend to spend less time with them in medical rooms. Documentation is different. And physicians just report being very frustrated with these patients and talking to them differently because they feel frustrated. Next slide, please. Which leads us to what can we do? And I really love this part of our talk because all of us care about people. Otherwise, we wouldn't have gone into these helping professions, right? So we can really be part of the solution by engaging in compassionate care. Next slide. And compassionate care really looks like being very non judgmental, being respectful of all individuals, being supportive, helping people where they're at, um, really being active listeners, acknowledging that obesity is not just one thing, right? There's so much we are learning about obesity, in terms of genetics, the environment, the food environment. It's so complex. And it is definitely more than just calories in, calories out, right? And it's definitely more than like people being responsible for having obesity. People are not responsible for that. They have tried so many times to try to change their body shape and size. It's just a very complex disease. Um, and we want to make sure that we prioritize families and kids' autonomy, dignity, and emotional well being. Next slide, please.
So thanks, Eileen. I just want to echo, I'm really glad that you started off with this sort of topic. We talk about um, weight bias and weight stigma, and sometimes we really don't give it enough emphasis, I believe. We're going to be talking about a lot of things that I think some of you may go like, well, these are things I know I should be doing, but do they really make a difference? And what we're here to tell you is these things really do make a difference. Spending time to acknowledge what your patients are going through, forming that connection with them is really critical. I made so many mistakes when I first started into this area where I thought that by, like by shocking people and by making them really understand how serious weight was, that they were really going to somehow have this epiphany and then, go on to lose weight and be very, very healthy. I really think it's important that we drop back as clinicians and really focus on what our patients are really going through, because they're all going through very individual things. And the science tells us we have got to pay attention to these things. This is not just it is a feel-good thing. It's the right thing to do, but it's also what the data tells us we need to do if we're going to be effective in this area. So I can't stress enough that this is a really critical piece for those of us who are serious about helping our patients. We have to work at our own weight bias and weight stigma. And I love the distinction that you made there, Eileen, between the two. I rarely see a good distinction between the two, but I really like the way you did it. And I think that it's something that we may give it a little bit of lip service. It's a linchpin to moving forward with being effective with your patients. Is we got to address weight bias, weight stigma, and we need to know how to address it. One of the things that I got to be a part of that I really had fun with is the role of the pediatrician in the promotion of healthy, active living. This is a clinical report. AAP kind of has these, I would say, really sort of these three big documents that have come out that have really been, we hope, are guiding principles for you as you're dealing with weight issues with your patients. And there are these three things. We did the first thing that came out was a policy statement around bariatric surgery that came out a few years ago. Then the big clinical practice guideline, which had the most data behind it, are on the treatment, management and treatment of obesity. And then also this last document, which is a clinical report, which we really need more data on obesity prevention, but it's a clinical report that superseded what was called the old clinical report on obesity prevention, which is the clinical report on the promotion of healthy, active living, which really, again, that's what we're talking about. It is about obesity prevention, but it's really about promotion of healthy, active living, and the wording like that about saying that we're here to promote healthy, active living is really important. I think if those of us who wrote this were sort of at first taken aback, thinking that we we're going to be making an obesity prevention document, and we are, but we really were received with the response from the reviewers saying, like, this really needs to be about promotion of healthy, active living. That wording is important because we don't want to immediately get into the struggle over weight quite as much. So at any rate, I'm just here to say obesity stigma, weight bias, weight stigma are very important concepts. Wording is important. And it's science-based that we need to really be paying attention to it. One of the things that we also talk about, and this feels like it's just a good reminder. I think we all learned this years ago when we, first time in medical school, where we were saying, we don't refer to a patient as the diabetic in room 4. We really talk about people being people, and they have disease processes. So it's not a patient really with obesity. It is a patient with obesity as opposed to an obese patient. It may feel a little awkward with the word overweight. After you use it a little bit, I have no problem. I'm sure Eileen feels the same way too. Like, I have no problem with saying someone with overweight. It feels awkward maybe at first because you think about that as an adjective, but it really matters to patients when they're not defined by this status. So they're a patient with overweight, a patient with obesity. It's part of who they are. It doesn't define who they are. What are some other things that we can do in practice? There's some very specific things. This was another policy statement that came out on weight bias several years ago by Rebecca Poole and Stephen Pont. And there are some very concrete things that you can do. If you're looking for things in your office going like, well, maybe am I practicing good weight, avoidance of weight bias and weight stigma? There are some very specific things you can look at. And the AAP has some specific resources for you to critically look at your office. Are you doing role modeling? It's not that we have to be perfect all the time. I think we all have to, our patients, it's good for our patients to know that we also struggle. It's not about us, but I think it's important for them to know that, like, hey, I know Dr. Bowling struggles with this too. This is something that's near and dear to his heart because I know that this is an issue, has been an issue for him as well. Language and word choice is important. The way you clinically document can have an impact. And the AAP again has some great resources on how you can document appropriately and help your staff to create a clinical environment where we're not promoting weight bias and weight stigma. It can be things like, making sure that your scale is in a private area, that we are weighing patients at the appropriate time in the appropriate way on scales that actually can accommodate them. It means that we know how to do some behavioral change counseling appropriately. It's interesting to see over the years, we used to talk about motivational interviewing as like, oh, this is something you might consider doing. Now it's like you almost have to. If you're going to be serious in this area, you really almost have to have some basic proficiency with motivational interviewing. And I'm really heartened because there are a lot of people who really work on honing their skills with this and incorporating this with a lot of other things like like medical decision making and other principles that we know that empower patients. There's also some good screening tools out there that can help you avoid bias and stigma in your practice, so we can use the proper language around this. So again, just going back to this, it's obesity prevention versus promotion of healthy active living. The issue is they're really both for everybody, but I really feel like when we talk about promoting healthy active living, we really are talking about this for everyone. And it allows you to very easily avoid the trap of people saying, oh, we're healthy at any size, which there's legitimacy in that, but also we are legitimately worried about certain illnesses, certain conditions that are exacerbated by excess weight. So we're really trying to the goal here is to make everybody healthy and happy, and keeping the focus on health at all points in the process. If we look, we should always be very honest about some of our understanding our limitations around BMI and weight. BMI is not perfect. It's the language that we use. It's something that we have to talk about, but it's not something that is perfect. And it's interesting in writing the clinical practice guideline. It's a very BMI based document, and one of the very first statements out of the gate is BMI isn't perfect and we need to get past BMI. So there's clearly a gap here where we need better ways to talk about weight status more than BMI, but it's kind of what we've got right now. We just need to be aware of our limitations and how to interpret it. I always say it's a vital sign. You got to take a vital sign. A resting heart rate of 51 may be a highly conditioned athlete. It may be first degree heart block. It's up to the provider to figure that out based on what the result is. We need to talk about weight and its connection to health, but weight alone does not indicate unhealthiness. It's the truth. And you can be healthy, but we need to really talk about what implications excess weight might have for certain patients. So talking about obesity as a disease and as a chronic disease is both a controversy and it's an opportunity. You're gonna wind up with people who have very strong opinions in both directions on this. Keep the focus on health. What's the provider to do? Do you throw up your hands and say, I can't, I don't know what to say to this? We keep the focus on health is what we do. Well, the clinical report on the promotion of healthy active living, when you think about this, when you think about what does promotion of healthy active living really look like, it really is in 4 zones. And this, if you are a consumer of popular media like I tend to be, this echoes a lot of other work that you see out in the community, of other work of other people who have podcasts and other things. There's a lot of things that go into what your weight status is. It's nutrition, it's physical activity, it's sleep, it's social emotional wellness. And under that, I'd also say, that screen time has a big impact on a lot of these areas, kind of running through all of this. But it's sort of these 4 domains. And I think, one of the things that we talk about it's frustrating for some people with obesity is it's very complicated. As Eileen said, these kids come to us with a really complicated process. You have to kind of love chaos a little bit in order to succeed in this area. You have to embrace the complexity, embrace that these four areas are going to be interacting with each other, but they're four areas where you're probably going to have an opportunity for improvement. Along nutrition, what kinds of things are we talking about? There's a lot of content as a provider that you can go after with your families. Okay, so in the nutrition zone, it might be about avoiding fad diets. It may be talking about paleo and things. You may have an opportunity to really promote the child's involvement in things. And that looks very different for a young child than it does for an adolescent. But that might be a zone around nutrition. Like with a young child, what I mean by this is, with a young child, do we work around introduction of foods? Do you see that as an area of potential intervention with a family? With an adolescent, does it mean like, hey, let's have a talk about what are you finding the challenges? What are the issues for you around fast food or sweet drinks? But really involving the adolescent. It might be about creating mealtime environments. It might be about ultra processed and processed foods. It can be about a lot of different things. And so in the nutrition zone, it's very age dependent, but there are a lot of areas that you might explore, that you might find, and they're all valid. You can't, I want to remind everyone, you can't do it all. That's why obesity seems so intimidating. It's like, I can't do all this in a 15-minute visit. You absolutely cannot. But you want to figure out what might be an appropriate topic in this zone. So let's talk about activity. What does that zone look like? What are some opportunities in that area? It's very individual. We know that activity rarely works when you say like, oh, you should go out and start running. Well, if you hate to run, that's not a very good suggestion. So it's very individual. It's very dependent on the resources that you have. If you live in a neighborhood where it's unsafe to go outside, outdoor activity is not going to be a great choice. I had, being inspired by patients. I remember a grandmother actually, who was a caregiver for a child. I live in the North Avondale part of Cincinnati. Parts of it can be kind of sketchy. And I had a grandmother who was a caregiver for a child. She said, Dr. Bowling, this is all well and good what you're telling me, but my first job is to keep my child alive when they go outside. And I'm like, you're right. That is a higher priority. So it's very much affected. It takes time to find an appropriate activity target. And I guess what I'm saying is to try to free you up from going down roads where you're like, I don't have time to do this, so I'm going to do a schlocky job on this. Drop back, take some time, figure out what might be a good target, especially in activity. Because not only is it very individual preference choice and resource guided, it's guided by things like, are they competitive? Are they not competitive? Do they like group activities? Do they like individual activities? It's all sorts of things. Do they like aerobics? Do they like resistance training? So it's all sorts of issues. Indoor versus outdoor, as I just mentioned. Sleep is another area that's really important that we know, and is another great topic if you're getting serious about this zone. The connection between sleep and weight status. As Eileen mentioned, there's a lot that we don't know about weight management. A little quick aside here. Those of us like Eileen and I are both get called sometimes by AAP to talk about certain topics. And I was approached by a reporter talking about the Make America Healthy Again movement. And I'm like, there are things that I'm like very excited about it. I personally, I don't think cutting research in the area is a really good way of doing it. Because we have so many questions. And that was one of the things the reporter was saying to me. He said, like, well, we know what to do. We just need to do it. And I'm like, no, we don't. There's a lot we don't know. Sleep is one of those areas that we know has a big impact, but we don't know all the ways that it affects people hormonally, from a neuroregulatory standpoint. It's really complicated. It's about weight, certainly, but sleep is a great target for a number of other areas as well. The one that I think, sort of gets short shrift, but is really important, and we're beginning to understand it more. Addressing social emotional wellness is really important when it comes to weight management and really important when it comes to promotion of healthy, active living. It's about parenting skills with young kids. It's about screen time and avoiding too much social media with older kids. It's about addressing weight bias and weight stigma that's out of the zone of your office. It's one thing to show it in your office, but it's helping them, equipping them to how to deal with this in a very hostile world, in a world that really preaches one body type, one body size. And then they get messages about like, oh, you shouldn't worry about it at all. And anyway, it's important to address. There's also a strong behavioral health connection. Kids, not only does it's a very much chicken and egg sort of phenomenon. People who have underlying behavioral health issues have higher rates of obesity. People with obesity have higher rates of other behavioral health challenges like depression, anxiety. So it goes back and forth. And so breaking that cycle, addressing social emotional wellness is a really big piece. So complicated enough for y'all, right? So you've got a ton of targets going on here. So your job as a provider is to find out the appropriate target and then start figuring out a game plan for addressing that. And that's where Eileen comes back in with once we found a target.
I love everything Chris just said. So I definitely agree. Like, I just want to put it out there, right? Like, obesity is such a complex process, right? It's such a complex thing that happens to our bodies and to the bodies of the kids and families we see. Um, but I am here to say, like, one of the things that I often talk to families about is it is not my job to tell people what to do. I help people figure out what they want to do, and then we talk about how to make that doable in their lives. And I usually fall back on I am here to meet people where they're at, right? And if something is going on for them and they bring that as a presenting concern or a presenting problem, well, let's talk about that, right? And the more we can kind of help people identify what feels doable to make a change, the more that they're going to buy in, and then the more likely they're going to be to have success with that in their own lives. Which leads us back to motivational interviewing. If you could do one click, please, Chris. Perfect. So, what is motivational interviewing? Another click. Um, it is a really good, very patient centered style of speaking to our children and families to help them really understand what it is they want to change and are able to change, and how we can kind of help them make a plan to make that doable and realistic in their life. Um, it can also help us kind of identify different levels of ambivalence or inconsistency in what they're saying, because a lot of times it's not that people don't understand that this is important to do, they just also don't know where to take that first step. So this way of speaking to parents and families and other individuals kind of helps us help them begin to make some of those first steps. And I usually tell families, we can make small goals because small things add up, right? And I think that that is really wonderful and helpful, because I know when people are given very large goals or laundry lists of things that they need to change, it can often feel very overwhelming. And then because they feel so overwhelmed or don't know how to implement in their real lives, they often kind of get that deer in the headlights and don't know where to start, so they don't do anything. And that is no fault of anybody. Um, we are there to be able to kind of help them make that doable. Next slide, please. So, what does motivational interviewing look like? So it's got a couple different fundamental tools. One of them is this acronym DARES. So really just helping people identify discrepancy. So that might sound like, you know, I I hear that you are really wanting to make changes, but also it sounds like you don't have time to do that. And I will sometimes like actually put my hands up so people can kind of see. And then I might say something like, um, if we were going to take one small step, what might that look like? Or what do we make of that, right? So that then that kind of elicits more conversation. We're really trying to not argue with anyone. That is not our job. We are just trying to help people kind of figure out, again, what they can do in their own lives. If you notice some resistance, that's okay. We're just trying to roll with it. And what that really means is saying, it sounds like X, whatever that X is, might actually be working for you right now. And that's okay, right? Because not everybody is in a place where they are able to make the changes that maybe even they want to make, or maybe those changes aren't as important to them as we think it is. Um, we want to make sure that we express empathy, and empathy is not sympathy. Empathy is really being able to kind of understand how somebody is feeling. In again, I'm a psychologist, so in that world of counseling, we really talk about reflective listening. And reflective listening is where we have heard what somebody is really saying, and then we label that with an emotion. It sounds like you felt really hurt then, right? Or it sounds like that was a very frustrating experience for you. And I usually tell, like, I used to teach counseling at universities. And I would have my new students who were so afraid to put a feeling out there and do that reflective listening because they were worried that they were going to get that feeling wrong. And I would say, it's totally okay if you get it wrong, you know? And it's a really exciting opportunity if you get it wrong, because then people can tell you that you've gotten it wrong. And then you can say, oh, I'm sorry, I think I misunderstood. Can you help me understand it better? Right? Or can you help me understand your experience better? Um, and we want to make sure that people can begin to feel like they're accomplishing even just small goals, because that really develops self efficacy, and we can totally build on that. So we're wanting to ask open-ended questions. I usually try to aim for what or how questions. Those are great ways to kind of open up that conversation. We want to affirm what people are doing. Even if people come back to me after having made a goal and they have only done it once, people will often say, well, I did it one time, so I didn't really do great. I get super excited if people have been able to do whatever they had wanted to do even once, because I'm like, that's fantastic. Tell me what happened that allowed you to do it that one time, right? Um, Reflecting on what they've been saying, doing a summary at the end. Um, we're going to talk a little bit about like readiness rulers, and I often think about like exception finding. So, again, in that example where people have managed to do their goal once, that's amazing. How did you make that happen? What was the exception there? What made that situation occur more often? Next slide, please.
So one of my absolute favorite motivational interviewing tools is the readiness ruler. And, as Eileen was saying, a lot of this is about, you're trying to turn this big ship around and you don't do it all in one fell swoop. You do it with little nudges at a time. And I guess if there's an overarching message that you get out of today's thing is little changes are awesome. Little changes are how we get there. So even if you're feeling like you're making really like I don't even know if I'm making enough progress on this at all. If you're making a little change, if they're coming back and seeing you again, that's a victory. Celebrate it and keep making little changes. That, like I say, that's how we turn the big ship around. Well, one of the little nudges that I absolutely love is when you have someone who is thinking about a change, is really getting proficient with the readiness ruler. This is one that I love it. So the readiness ruler, the thing that I've seen people kind of get a little bit different with it that I don't like quite as much is you'll hear people say, well, on a scale of 0 to 10 or 1 to 10, how ready are you to make a change? It makes no sense to me. I think we need to drill down a little bit. If we're going to do the readiness ruler in a true motivational interviewing sort of way, we're talking about someone's identified a behavior change. Okay, so someone has come to you and said, like, you know, Dr. Chavez, I do think it is a good idea for us to really look at this sweet drink habit that I have. I think it's something that we need to do. And then you can then use the readiness ruler. I want to break this into two aspects. So, how important is different than how confident are you in making the change? Both importance and confidence factor into how ready you are. Those two together determine how ready you are. You might think you need it to something, a behavior to be very important and for you to feel like you've got some self-efficacy around it, that you can actually do it. So you need both of those to be ready. So I think you need to ask both those questions in that way. I also think it's possible to have zero importance and zero self-efficacy. So I really like readiness rulers that don't start at 1, that actually start at 0. And there's another reason for that too, and I'll tell you why that is in just a second. So 0 meaning so you ask people very directly. So how important do you think it is to you to stop drinking sodas? With 0 being it's not important at all, and 10 being it's the most important thing in my whole life. So, and they'll give you a number. And then what you can do is you can say, why not higher? Which would then get you get them to explain why it isn't that important to them. But then never forget to go under, because then something magical happens. By going under, if someone says, oh, it's a 1. Oh, really? Well, why isn't it a 0? Because then you suddenly have someone who really doesn't think stop, they say they want to do this, but they don't think it's really all that important. But then suddenly you have somebody saying, well, it's not 0 because, I mean, at least you told me it's important. Like, I give you a little bit of credit for that, maybe. Or, so you get you'll get someone to argue on why that it might be more important. So you get someone who's if by going under, you get somebody to argue for the importance. And then you turn around and ask, okay, now that we've established how important this is, we then say, okay, now how confident are you that you could do this? And you can say, they might say, well, I think it's really important for me, but I just don't know how to do it. So I think it's a 3. So then you can say, why is it not a 5? And you can look at challenges they might have. But again, don't forget the magical piece. They say it's a 3. Why isn't it a 1? Well, maybe I could get my sister to help me. Or you know what? I kind of like flavored water a lot too. You know what? Or, boy, it's kind of expensive. The fact that, so maybe I could save some money by doing it this way. So again, you get them to start arguing for change. A wonderful little tool. You're not going to have an opportunity to use it all that often with just your weight management patients alone, but you can use it in other situations too. I use it all the time. Great tool. And then I will go to the next one here.
So, in one of the things that I've come to realize in obesity care is that people have so many barriers, unfortunately, that are not of their own making, right? Like, so many people come to us and they have had, unfortunately, so many experiences with trauma. Um, there are lots of social determinant of health factors that kind of go into people's everyday living, like living in a food desert, or not being able to afford fresh food, or not having transportation to get to visits, but then also microaggressions that have occurred to them throughout their whole life because of weight bias and weight stigma. Um, and so I like to think that we are one of the modifiable factors in this treatment. And the way that we work with families is one of the things that we can actually do to help give people a reparative experience so that they really create those really strong relationships and then come back to us, right? So I have kids that I have seen for a while who will say, I'm in therapy outside of here for all this other stuff, or I've seen lots of other medical providers, but I never talk about my eating or my weight unless I'm here. And when you ask about it, it's because they often feel judged in other places. So I like to think about how can we give that reparative experience for people, because I feel like that is one of the few ways we can get people to sort of trust us enough to help them start to make changes. So again, these are just the 4 processes of motivational interviewing. So developing that rapport, I think, is essential. I think it is the foundation of care. Um, Really sort of helping people negotiate an agenda. And I'm sure people have probably heard of SMART goals. Another way to think about it is smarter goals, and the E stands for evaluated and the R stands for reviewed. Um, but just helping people really sort of identify even small changes that they want to make and then being very specific. So it looks very different than like, I want to exercise more, which is great. But how do we specifically do that in your real life? And when I help somebody make a very specific SMART goal, I want them to actually be like visualizing what that's going to be like in their life, because if they're able able to visualize it while they're with me, I think it's more likely to happen when they're not with me. Um, and then we want to help people just kind of like how Chris was saying when he was talking about the readiness ruler. We want to cultivate that change talk. So we want them to start to argue for making that change themselves, which I totally agree. That's that magical piece. And I've already talked about collaborating and talking about SMART goals. And then when they come back next time, really reviewing that. So the 6 stages of change are really that pre-contemplation, like, I don't know, what are you even talking about? Contemplation, I have to think about it. Preparation seems like a good idea, not sure how to go about it though. Action, let's do it. I'm actually going to go out and make some changes. Maintenance, I'm continuing to do it. I'm really trying. And then that termination piece is I did it. But for a lot of this healthy active living that we're talking about, there isn't really like a termination. We hope people kind of just take these behaviors and incorporate them into their lives and their families' lives and just continue them throughout their life.
One of the things too that I think is so interesting about motivational interviewing, when you see that trans theoretical model to Eileen, is like, with your patients, be patient with them to go back and forth on that scale too. They'll flop all over the place. Like they'll go into pre-contemplation and then they'll go into contemplation and then they'll drop back out and they'll come back in again. They'll kind of go all over the place. And that is very, very, very normal for that to happen. It's really great to look at your own ability to have an impact on this. As Eileen said, the first step is creating that relationship, and it's important to really cultivate that with our families by role modeling, by really encouraging their own relationships with each other, by practicing that empathy and be culturally sensitive and aware. Those things are really, we've said it a million times, they're just really very important. So with that, what I'd like to do actually, if you guys are up for it, and we'd love to have some questions also, but Eileen and I are going to do a little bit of role playing here. And I'm going to be Malik to start with. Malik is a 9-year-old male presenting to primary care, seeing Dr. Chavez in the clinic. I live with a single mom, my brother and sister. My BMI is in the 92nd percentile for my height and weight. I've gained 9 kilograms since my previous well child check and have grown an inch. I spend about 4 hours each night playing video games, and I prefer that to going outside. The family describes their neighborhood as being dangerous, and they do not have a yard. So I am with Dr. Chavez right now, and I am Malik.
Mm. Hey, Malik, how are you today?
Good, Dr. Chavez. How are you?
Doing okay. Thank you for asking. I was just wondering if you could tell me a little bit about what's been going on for you at home since we saw each other last.
It's been pretty good. It's been, I'm in 4th grade now, and it's okay.
Nice. What's one of the things you feel most proud of since you were here last time?
You talked with me a lot about sort of trying new foods at school, so I've been trying to do that. Like they had some different types of fruit. Like there was some fruit that was in a can that I tried this time that was okay. I don't like it because it's slimy, but I could eat the stuff that was out of the can.
That's amazing. Do you know the name of the fruit that you tried?
It was a fruit cocktail.
Ooh, okay, great. What did you think of it?
I thought it was okay. It was okay. I like the cherries.
That's great. Um, is it okay if I ask how eating's been at home?
Sure.
What's eating been like at home?
So we usually eat out a lot. Mom was working like 3 jobs right now, so we eat out a lot. We eat, so my favorite is that she gets a lot of pizza for us. So that's one of my
Mm.
favorites.
What kind of pizza do you all get?
I like the pepperoni pizza.
That's delicious. So I am wondering, Malikan, if we were gonna make one small change even to the way you're eating at home or at school, or to just kind of move in your body a little bit more, what would be someone that you think you'd be willing to do or want to do?
Well, I don't know if I could eat anything too different because it's what we have.
Mhm.
But my mom's always on me about playing too many video games.
Oh, okay. Right. How often are you playing video games?
Yeah, I usually in at night. So usually I do it before I go to right before I go to bed.
Mhm. What do you enjoy about playing video games?
It's just fun. It's fun. It's like it's fun. I can play. I don't have to worry about anything. I don't. I can stay. I can do it as long as I want to. I can.
Mhm.
Sometimes there's somewhere I can play with friends online too.
All right, so it's an opportunity for you to also spend time with your friends.
Hmm.
Yeah. And when mom talks to you about video games, what does she say?
She just tells me to get off of it. She said I'm playing it too much, but I'm like, it's fun.
Mm, mm. Do you do other things with your friends too?
Yeah, we do sometimes. Yeah, we sometimes play basketball up at our after school program.
Oh, that's so good. What do you like about doing that?
It's really fun. I actually like to sweat a lot too when we get out there and really run around. So that's pretty fun. And I got a good jump shot.
Oh, that's really cool. I'd love to see that someday. So I heard you say that, mom just kind of brings in the food and she's working a lot. And you really enjoy eating the food mom brings. But I'm wondering if we could maybe talk about just moving your body a little bit more or a little bit differently, especially since you really do enjoy basketball. What do you think?
Sure.
Yeah. If you were going to move your body even just a little bit more, what do you think would seem doable or what do you want to do?
Well, there's another, I mean, we're not too far from the Y. I've been asking my mom if we could go up to that. It's like once a week, up at the Y that's down the street from us. And they have open basketball on Thursdays.
Oh, that's really cool. Have you been there before?
Once, but
Once.
I want to go again, actually.
How did you get there before?
So, friends from school showed me how to take the bus to get there, and we had to walk a little bit.
Oh, okay. And you went with your friends?
I did
That's really
right after
cool.
school. Mhm.
Yeah. Um, have you talked with mom about going again?
No, do you think we could?
I think we totally could. What would you want to say to mom about it?
That I'd really like to do it, and that it would be. I think she feels like it's a lot going on right now, but
Mhm.
that I think she's afraid that I'm gonna like start doing it and then quit right away because I've done that a
Hmm.
couple of times too.
And what do you think about that?
Well, I have quit a couple of times.
Hmm.
So yeah,
Hmm.
she's kind of right. I have quit a couple of things, but it's because I didn't like it.
Yeah. Yeah. You didn't like what you were
But
doing at the time.
yeah, but I guess I could say to her like, I'll do it a certain number of times. Like if she'll take me, I'll make sure I do it a couple of times without complaining first.
And I think what I'm hearing the difference is you actually really do enjoy playing basketball,
I do.
which is maybe different than some of the other things that you've tried in the past.
Definitely.
Yeah.
Definitely.
So I'm wondering if maybe we could talk with mom about the possibility of you sort of at least trialing going to basketball with your friends on Thursdays and just maybe trying it for what do you think? Do you think like we could try it for 1 or 2 weeks? What seems
Oh,
doable?
yeah, I bet even 3 or 4. I bet 4 weeks.
That'd be amazing. Maybe we should talk with mom about trying it for 4 weeks and just seeing how it goes.
Okay. I like
Yeah.
that.
Okay.
Okay.
Perfect. Thanks, Malik.
Okay.
We'll talk to your mom.
Sounds great. So we sort of trying to let him run the show there as best we can. Um, do we have time here for another one, or
I
maybe we
don't know.
should?
We might need to go to questions.
Yeah, let's go to questions. So Javi, if you want to unmute yourself, and we'll kind of go through some questions.
Yeah, everybody, if you would like to either unmute or use the chat to ask any questions, now would be a great time. And we'll give a couple minutes for questions to trickle in.
But I think, one of the things that you did too, Eileen, that I like is just sort of letting me I didn't know where I was going to go, where Malik was going to go with that. There's a lot of different targets there. Like, we could have gone, we could have, but we didn't. Eileen, if you notice, Eileen did not go after everything. Like, we could have said, like, let's get rid of the screen time an hour before. Let's, try to eat something different at school again. We didn't drill a whole lot into was the fruit cocktail into heavy syrup. So you can get really bogged down. You can really get distracted. So if you noticed, what Eileen did was she really went after a topic, after a target. And again, our overarching message is keep it simple. This is a complicated, multifactorial area. You're going to have time. Take advantage of a longitudinal relationship.
And I would say, like, if people give you something that they enjoy or want to do, that's the kind of direction you want to kind of go in, right? Like I think Chris is totally right. There are so many ways and so many changes that we would hope people could talk about or want to talk about. But if we are helping people with what they really want help with in the moment, and we find something that they feel is doable, that's a great first place to start. And then once you kind of have that relationship with them, they're going to come back to you. And I think we saw the question, there's a question of how often do we see them back, especially if they're ready to make changes? Um, I know, and Chris, you can say how often you would see them back, but we, because of the way our clinic schedule is, we try to see people every 4 weeks. That is not always doable, but that is, you can also do other types of check-ins in between. So sometimes we'll send like my chart messages if you have that capability, like on your EMR. Sometimes we're able to do just like really brief touch base calls. But ideally, maybe you would see them more often, but I usually see people about every 4 weeks.
And I think that's a great way to use your motivational interviewing. What kind of support do you need on this follow-up? Like, how soon do you need me to circle back with you? Do we need to check this after you've made it to basketball 4 times? Do we need to check in with you after 2 times?
We have another question in the chat. How do you keep the conversation on the healthy behaviors and support body diversity within your work if an individual's body weight is in a higher classification, meaning that is their healthy weight?
Do you want to take it first, Eileen, or do you want me to?
You go ahead and take it, Chris.
So I think that, it's really, that is a great thing to talk about. I mean, I think that you have to really see where they are with their weight. If they are on the upper end of things and they are healthy and they are happy and everything's going well, you've done an appropriate evaluation for them, which is going to be our next section. Then your work may be done there. And that may be something that is, where BMI is not perfect. It's like they may not fulfill exactly what you're thinking, but if you're happy and healthy.
And one of the things we have here is we have an InBody machine, which just looks at body composition. I know not everybody has that, but we see a lot of kids who are athletes. And so their weight may be a little bit higher, meaning also that their BMI might be a little bit higher. But when you do body composition, we see that they have a lot of muscle mass. Right. And as kids continue in sports, like we have kids too who, in the fall start football training or conditioning. And then they come back and their weight has actually gone up, and then you do their body composition, you find out that they've built muscle. And initially, if we kind of didn't know that, kids might have been really down or really upset. Which is why I always really like to bring that focus to behaviors, because behaviors are those things that we can actually like change and do day to day versus like what that number on the scale is.
We have a couple more questions in the chat. I will just take a minute to run through them. And we'll also, you can see here on the slide, Dr. Boley and Dr. Chavez have included their email, so you can always follow up with them or with me, and I'll pass it along to them. We'll go through one or two more. Do you think it is important to mention a child has a high BMI or not even mention weight and by using motivational interviewing come up with goals?
So I think it's important to discuss it and put it into terms what this means for them. It's a non-judgmental thing. That's again, it's a vital sign. I think in some ways, it's a HEDIS measurement that you're obligated to talk about it. But I think it's important to talk about it. But I think it should not be as we've learned over the years, that it is a jumping off point for discussion. It's not the be all end all, I guess is what I would say. But yes, I would talk about it, but I'd put it in context.
And I think that dovetails nicely with the question kind of down in the chat about thoughts on pros and cons of showing growth curves. And so I usually say it's always helpful to ask permission before you show somebody a growth curve. And it sounds just like this. Would it be okay if I show you your child's growth curve today? Or to like an adolescent, would it be okay if I showed you your growth curve today? And then I usually have a spiel that I give right after that because people usually tell me yes. So I say something like, please know I understand that each of these points on this growth curve is a weight. Um, I don't really care about them as weights. I care about them as pieces of information, but even more than that, I kind of care about the like what they're doing. Are they going up? Are they staying the same? Are they going down? Right? And I care about the points or the things that happen in between those points because those are the behaviors that you're doing every single day that can kind of help determine what that curve is going to do. And if you talk about it as kind of like a story, people will often say, like, I usually hover over the points and say, well, what was going on in your life in October of 2023? And people will be like, oh, that's when my parents got divorced. Or that's when I was in marching band. But you get more of a story. And then you can start to talk about, like, oh, you were in marching band. I noticed that the trend was going down. What were you doing? Well, I was outside with my friends all the time and I was moving around. Oh, so it sounds like really being active with a group of people that you really enjoy and doing like a shared activity really was an amazing thing for you and it helped. It helped you feel like you were kind of getting to be where you wanted to be with your health. And that's a really good jumping off point. It also kind of helps identify like emotional eating. So if people have had significant stressors in their life, oftentimes you get to a story of like um, a bunch of weight-based teasing and bullying that can kind of come out and you can see on that growth curve. And then you can talk about that and kind of help people recognize maybe I was engaging in emotional eating. And then you can kind of help with interventions for that. But that's usually the way that I talk about the growth curve. But I would say, first of all, always ask permission before just kind of like showing it.
Thank you, Dr. Bowling and Dr. Chavez. I do see the other questions in the chat, but at this time, just to be mindful of everybody's schedule for the day, I will have Dr. Bowling and Dr. Chavez respond to the questions and include those in the follow-up email. So thank you so much, everybody, for joining today and for having such a wonderful training, Dr. Bowling and Dr. Chavez. If you look here on this slide, please check your email to claim your CME or MOC credit. We do ask that all participants complete this short survey, even if you do not plan to claim credit. This will enable us to collect endpoint data to measure the rigor of our programming. Once you complete the survey, you will receive a certificate within 10 days. And again, I'll follow up with these directions via email for your reference. You can go to the next slide, please. If you enjoyed today's session, please join us for the second part on May 22nd. That's 2 weeks from today at noon. Please scan the QR code on this slide to register. It will also be included in the follow-up email. I'll give a second to scan that QR code. And then if you have any questions or suggestions for future PMP programming, please call or email me at the contact information listed on the slide. This concludes today's training session. Thank you for your time and energy, and I hope to see you in another Ohio AAP training.